Good evening, friends. Welcome to our Tuesday webinar from the Department of Critical Care Medicine, Yashoda Hospitals. I'm Dr. Kaladar from Yashoda Malakpet. Today, I will be speaking on the topic steroids, the role of the steroids in critical care, the current evidence, and the clinical controversies. To discuss with, we have next expert panelist with us, Dr. Josh Chako sir. I think there is no introduction needed. Actually speaking, the nationwide everybody knows surname, is very renowned. Sir is a senior consultant at Narayana Udayalaya. Sir's blog spot is there, like a critical care blog spot, which is very famous. Chaco's critical care blog spot. So I read through the blog posts regularly, get a lot of immense knowledge, simplifying things, very complex concepts into simplifying simple knowledge. So where you can easily get the crux of the topic. So I immensely look at it, and whatever the insights I get from those articles are very helpful. And sir is very well renowned speaker, and he has written a book on controversies in critical care. So touching each and every topic and telling about that. In fact, actually today's topic, I had taken some of the material from sir's book, where role of steroids in critical care. There is one chapter in 15th chapter. So where I have taken some of his concept there, whatever sir has written. So this is how the sir is very well renowned. Welcome you, sir, on board.
Thank you. Thanks very much, Dr. Kalada. Happy to be here for this meeting.
Yeah, camera is off, I believe.
Yeah, we have with the moderator, Dr. Venkatraman Kola sir. Sir just now joined. Welcome, sir. So you are.
Thank you, Kaladar. Thank you, Joe sir, for accepting our invitation and being a part of this program. It adds a lot of credibility, and I think there is a lot of enthusiasm to listen to you, your expert panel. And Kaladar, you always been on the forefront of bringing some topics of interest. I think in the last recent times, we have been hearing about the role of steroids in a different parts. So I invite Dr. Kaladar, who is the head of the department critical care medicine in Yashoda group of hospitals in Malakpet. He happens to be also the coordinator for the last maybe a year or so to this master classes, taking these classes to a new heights. And today he felt like we have gone through a lot of controversies in steroids, and new articles, new guidelines, and in many discussions. Whenever a pneumonia discussion comes, the pulmonologists, the critical care, the physicians keep on asking me, do you use steroids in pneumonia, and what is the criteria to use in pneumonia? What about in influenza? What about in other non-influenza pneumonia? What are the categories? So it's just not pneumonia, but we know steroids has been a component of our um, treatment list in many other conditions, but they always been gone through a controversies, always been gone through some amount of swing of pendulum, yes, no, yes, no. So today, Dr. Kaladar will bring us the topic of steroids in critical care, the current evidences and clinical controversies. Over to you, Dr. Kaladar.
Thank you, sir. Thank you for that kind introduction and introduction to the topic, sir. So we'll go forward with our topic proper. So to start with, I will explain about this slide, where I think the physiology, the background physiology of corticosteroids is very, very important for all of us. So if you look at, sorry, are my slides visible?
Yes.
Okay. So if you look at in this picture, the physiology proper of the steroids at rest and during stress, it will be. So if you look at the hypothalamo-pituitary adrenal axis is the one which regulates the steroid, especially the steroid functioning in the body. So depending upon that, the corticotropin releasing hormone comes from the hypothalamus, goes to the pituitary and stimulates pituitary to secrete the adrenocorticotropin hormone, ACTH, where it will be acting in a feedback, positive, negative feedback, depending upon the cortisol production. It stimulates the adrenal glands to secrete different types of the hormones called as aldosterone, cortisol, adrenal androgens, catecholamines. As everybody know, they have their own role. Suppose aldosterone maintains most of the time sodium balance. Cortisol is the stress hormone. Most of the times it is involved in the flight fight response against stress. And catecholamines, most of the times they regulate, adrenaline, especially noradrenaline, adrenaline, they regulate the blood pressure and autonomic nervous system. Adrenal androgens are helpful for secondary sexual characteristics. So they have their own role. The interest for us is cortisol and catecholamines. So if you look at, this is the normal feedback that happens in the at rest or otherwise normal healthy individuals, as compared to a patient who is critically ill, or otherwise the patient who is coming to our ICUs most of the times maybe with septic shock, severe ARDS, polytrauma, burns, very high stress involved, very much hyperinflammation there in the body, leads to a lot of other changes. Other than the HPA axis, there are independent mechanisms like autonomic nervous system induced ACTH production. Inflamed tissues can stimulate CRH, ACTH independent cortisol production. These all lead to the increased CRH, and then it leads to the increased stimulation of the adrenal gland, generally to improve the tackle the flight and flight response. So other than that, there is cytokine induced HPA axis activation also. But other interesting thing is the feedback loop as it happens in at rest is very much disturbed. This is dysregulated feedback loop, which may cause haywire in the HPA axis, leading to high or low the cortisol production or otherwise the catecholamine production. In addition to that, there are some peripheral mechanisms like altered corticosteroid metabolism can be possible, and at the same time, the tissues may develop resistance, like cells may develop resistance to corticosteroids and they become unresponsive. This is the background. So, what is generally the concept, I think, much talked about since long is CIRCI. We call it as critical illness related corticosteroid insufficiency. As we were talking in the picture, where there is impairment of HPA axis, inadequate cellular corticosteroid activity, insufficient glucocorticoid mediator anti-inflammatory processes. So the amount of cortisol production, whatever happens, is dysregulated, and at the same time may not be able to tackle the amount of response may not be able to tackle the stressor response that happens at that point of time in a patient. So CIRCI is a state of systemic inflammation, dysregulated HPA axis, altered cortisol metabolism, tissue glucocorticoid resistance. So we'll go one by one. Mostly I will be talking about the role of steroids in sepsis, septic shock, and at the same time ARDS and the pneumonia. These are the most commonly that we encounter in ICUs. Other than that, there are most of the time straightforward indications. So what's the role of the steroids in this sepsis? What happens? What is the background rationale? If you look at the pro-inflammatory cytokines, they are there in sepsis, which increase to much larger extent, leading to sometimes suppressing cortisol response to ACTH, and they compete with glucocorticoid functioning. So it can lead to critical illness related corticosteroid insufficiency. So this leads to the hypotension, precipitating organ failures. The response to vasopressors may not be adequate because the corticosteroids are involved, especially if you look at here in the vasoresponsiveness of the blood vessels. If you look at how the steroids help, this is what I have taken from Shakosa's book, a very good diagrammatic representation where the steroids actually decrease nuclear factor kappa beta, where it is a pro-inflammatory cytokine, and it increases response to vasopressors. As you give noradrenaline or vasopressin, the vasopressor responsiveness of the blood vessels will increase when you give steroids. And there is a decreases synthesis of vasodilators. The vasodilators, most commonly what we look at is inducible nitric oxide synthase, where nitric oxide is to the extent leads to the vasodilation, that synthesis will come down. And there is increased response to vasopressor, nothing but norepinephrine. And there will be sodium retention because of the mineralocorticoid effect and increased systemic vascular resistance. And there will be an associated decreased neutrophil aggregation. This is sometimes leads to a bit of decreased immunity. So nothing but it will help in cytokine storm. So when the first study, I think the landmark study, what we can say, which is a properly randomized control study, was performed by Jilali Annane in 2002. So, which was published in JAMA, where they looked at the effect of treatment with low doses of hydrocortisone around 50 mg, 6 hourly, which is a dose of 200 mg, hydrocortisone of 50 microgram, the enterally given. Sorry. So to patients who are septic shock. So here what happened is in this patient, they performed the co-syntropin test. So they have given the co-syntropin of around ACTH stimulation, nothing but 250 microgram. Looked at after 1 hour, what was the response. The patients who have less than 9 microgram of elevation of the cortisol, they are called as non-responders. So the non-responders are nothing but they are not able to mount adequate response to the infection. So these non-responders, when they are supplemented with the hydrocortisone and fluorocortisone combination, have a very good response to the vasopressors, and they it's translated into a very good probability of survival with the decreasing 28-day mortality. If you look at in this Kaplan-Meier curve, where steroids versus placebo, the probability of survival in the patients who received steroids, those who are non-responders to ACTH stimulation test, is good compared to the patients who are responders, nothing but their cortisol response is adequate. They did not have much of a translation of outcome in terms of the mortality benefit. So there are Cochrane reviews, and most of the in 2015 the Cochrane review showed, which analyzed 12 trials, showed that the benefit is more in septic shock, less benefit. This is across most studies that the benefit in sepsis other than shock is not much as compared to septic shock. And there is an APROCCHSS trial which they performed again without shock. So here also they randomized to either hydrocortisone versus placebo. The same thing, no difference in the patients progressing towards septic shock, also not much. And even there are no other much differences in outcomes also. So some of the guidelines, like especially Society of Critical Care Medicine guidelines, I looked at, where they suggested in 2017 that against steroids in sepsis without shock, but giving steroids in septic shock. Here, actually, what they mentioned, even our surviving sepsis guidelines, after adequate fluid resuscitation and high dose vasopressors, the patient BP is not improving, then you have to resort to the corticosteroids. And they suggested using low dose and long course, less than 400 mg per day, and using for more than or equal to 3 days. So if you look at the different trials, which are landmark, we can say the corticosteroid load in sepsis, Annane, as we discussed, there is a good 28-day mortality dated back 2002, and subsequently Corticus study, where the septic shock patients, here only hydrocortisone was given as compared to the combination of hydrocortisone, fluorocortisone, Annane study, and there was no difference in 28-day mortality. And then there is ADRENAL study in 2018 by Venkatesh et al. Here also the septic shock patients, for more than 4 hours, if there is vasopressor, they had given 200 mg per day. This is as infusion. This is more, the study came from Angix across different countries, where the 90-day mortality was not very there is any difference between the patients received corticosteroids versus no corticosteroids. And again, Annane et al., again, they performed APROCCHSS study 2018. Again, whenever the Annane et al. Performed 2 studies, they used to give like this combination, fluorocortisone and hydrocortisone, and here vasopressors more than equal to 6. Again, the same thing. It translated into good 90-day mortality benefit and all-cause mortality at ICU and hospital discharge, with which was significantly lower with the corticosteroids. And then we were discussing about high-press, where only sepsis without shock, but there is nothing much. So this is how these are all studies were performed. The 2 studies which shown mortality differences, the Annane et al. First 2002 and 2018 APROCCHSS. So all these evidences, including 46 RCTs, they were SCCM guidelines purpose, they examined, where they found out that the corticosteroids reduce short and long-term mortality in septic shock, and they reduce ICU and hospital length of stay, and there were not much of any subgroup effects based on steroid type, dose, or duration, and no subgroup effects between sepsis versus septic shock. So when the all evidence they looked at, particularly in septic shock, as we were discussing, there will be large absolute effect, and beneficial in septic shock, as we were discussing 2017 when they looked at, it can be only after maximal resuscitation we have to use. So this is being reviewed, and again now the status is the steroids have to be used in septic shock regardless of any specific vasopressor dose, and it has to be maybe early started. You start simultaneously resuscitation and the patient did not improve much, started vasopressors, probably at that point of time early the steroid has to be started as compared to earlier notion. So, and the changes, if you look at patients with sepsis without shock, no steroids. With shock, compared to 2017 and 24, suggest giving corticosteroids without any specific vasopressor dose, we have to look at. And this is the about septic shock. So next is corticosteroid role in ARDS. So if you look at the acute respiratory distress syndrome, as we were looking at during pandemic of COVID-19, where the phenotypic differences between ARDS, hyperinflammatory, hypoinflammatory. So most of the times ARDS is acute diffuse inflammatory lung injury. So where the patient develop a lot of exudative injury leading to hypoxia, leading to severe ARDS. That is the rationale where the steroids may help alleviating these, especially the hyperinflammatory response. So the older clinical trials, if you look at dated back in 1998, Meduri et al., they looked at in patients severe ARDS. If the patient is not having any improvement after 7 days, they started. That means after 1 week. But still they could find the reduced the mortality in these patients. But the population is very small, 24 patients only. Annane et al., they did a secondary analysis of trial with septic shock patients, as we were discussing about Annane et al. Study. They looked at ARDS patients, they have reduced mortality. Midori again in 2007 performed methylpred versus placebo, also found reduced mortality. Tongyu in 2016, sepsis-induced ARDS improved pulmonary physiology, but mortality difference was not there. So the anti-inflammatory properties of the steroids help in curtailing the ARDS inflammation, leading to reduced markers of systemic inflammation like cytokine CRP. This leads to good improvement of oxygenation, reducing the duration of mechanical ventilation, and probably translating into reduced mortality. So the timing of steroid therapy in ARDS network study, which was published in NEGM 2006, Lazarus study, late steroid rescue study trial was published in 2006, where they recruited patients more than or equal to 7 days. And here the difference in mortality with methylprednisolone was not much. And if the patients received more than or equal to 14 days, that means 2 weeks after, especially, the mortality was on the higher side. This indicates late in the course of ARDS, if the steroids being started, it leads to bad outcome. So, suggested giving corticosteroids in early moderate severe ARDS with PF ratios less than 200 within 14 days, possibly as early as possible, I can say within 1 week. Of course, there are different clinicians like different steroids. Some people like methylprednisolone, some people like dexamethasone. So it is varying between different clinicians, but finally the outcome among them is not much different. So this is how they suggested the regimen how we can follow. If you look at the loading bolus 1 mg per kg initially, 1 to 14 days 1 mg per kg, and then 0.5, 0.25, and 0.125 until even 4 weeks in early severe ARDS. And if it is unresolving ARDS, the dose has to be increased to 2 mg per kg as compared to 1 mg per kg. And there the patients generally by day 7, it will be decided whether the lung injury score is improving or decreasing, and oxygenation improving or not improving. Based on that, they decide it is unresolving ARDS and increase the dose. And if you look at this is one of the more recent trial, DEXA-ARDS trial, much talked about across where in different conferences. The DEXA-ARDS trial, which was published in 2020, performed in Spain, patients with moderate to severe ARDS. So the PaO2 FiO2 of less than or equal to 200 with PEEP of, FiO2 of more than or equal to 0.5 at 24 hours after ARDS onset, randomized to either dexamethasone versus continued routine care. So the dexamethasone dose was 20 mg per day for 5 days, then 10 mg per day into 5 days. So here they have shown very clear-cut reduced mortality in this population where the patient received the probability of survival received dexamethasone dose for 10 days, they have a very good probability of survival as compared to the patients who did not receive. And everybody know that during COVID-19, the recovery trial was performed. So where they used 6 mg per day of dexamethasone for 10 days, where the dexamethasone receiving patients have decreased requirement of invasive mechanical ventilation, had a lower mortality and oxygen support. So in this, generally the patients who have gone on to oxygen support itself, they started steroids as compared to the patients who are not requiring the oxygen support. So all these studies, they looked at 18 RCTs. So steroids finally concluded that reduced 28-day mortality, a reduced duration of mechanical ventilation and hospital length of stay, and it may be different between different the pneumonias. Especially most of the studies excluded influenza pneumonia, and the steroids may offer moderate desirable effects. Lack of evidence, especially regarding adverse effects, hyperglycemia, any new onset infection, especially in patients who have influenza. They tried influenza-associated aspergillosis was also a possibility. Long-term outcome data was not available because steroids may have sometimes develop a patient develop critical illness, neuromyopathy, post-rehabilitation. How, what are other side effects were not very much evaluated across these studies. So they did not include much of any PF ratio as we were discussing. Patients who are requiring the oxygen itself, they started. So suggest finally the SCCM guidelines, what they suggested is giving corticosteroids critical ill patients, the ARDS, PF ratio and timing may not be required if the patient requiring oxygen support with high oxygen support considered as moderate to severe ARDS can be given. No specific regimen. Most of the people DEXA-ARDS regimen are following, but yeah, it up to the mark. Some we at our institute follow most of the time with Alpred. So the changes are suggest giving corticosteroids. No need to look at PF ratio, dexamethasone versus methylpred. This is about ARDS. Next is corticosteroids in community acquired pneumonia. The rationale for corticosteroids in community acquired pneumonia, again, pneumonia can lead to systemic inflammation, and the steroids will have anti-inflammatory and along with immunomodulatory effects. So most of the earlier trials, if you look at all these earlier trials, have a lot of heterogeneity. So the patients, some patients were included with severe CAP, some are only just hospitalized without severe CAP. So the variation in hydrocortisone dose, prednisolone, some used dexamethasone, methylprednisolone, so much variation is there. So overall, these studies, meta-analysis did not show any much of difference in mortality. Some secondary benefits were shorter time to clinical stability, shorter hospital length of stay. These were the effects. So other clinical trials subsequently performed shown benefit most pronounced, especially the patients who have a severe CAP. So if you look at, this is the landmark trial that is being published in 2023, where we were discussing much about this, where they excluded influenza pneumonia as part of the exclusion criteria, and they included severe CAP patients requiring ICU admission, and they randomized to either hydrocortisone versus placebo, which the dose was 200 mg per day for 4 to 7 days, followed by tapering dose. The results were, if you look at in this graph, death from any cause by day 28 in hydrocortisone group as compared to placebo group, 6.2 versus 11.9, around difference of minus 5.6 percentage points, which is a very good outcome where the results were reduced 28-day mortality, reduced requirement for invasive mechanical ventilation, and requirement for vasopressors. Sorry. So subsequent other studies like ESCAPE, REMAP-CAP, these studies were also being performed. REMAP-CAP, most of the patients were included are the COVID patients. And escape, as compared to CAPE-COD, is the one which showed lower 28-day mortality. There are some limitations in this study, but the steroid was started earlier, 24 hours earlier, compared to escape, where they started a bit late. So this may be translated into good outcome, but other like the REMAP-CAP study showed mixed results across settings, but in patients who had COVID-19 had a good outcome. These are other studies that were there. So all 18 RCTs were included in these guidelines they reviewed. So 10 trials for severe CAP, 8 trials for less severe CAP. So finally concluded that the hospital mortality, especially in patients who have severe CAP, reduced along with good improvement in less need for invasive mechanical ventilation, and duration of ICU and length of hospital stay decreased. So they all have desirable effects, especially in severe CAP. Potential adverse effects, as we were discussing, is about hyperglycemia, especially the patients who are diabetic tend to increase their glucose. We have to be careful. So how do you define where it is severe CAP means what, especially? American Thoracic Society and IDSA defined, these are all definition where the major criteria, minor criteria, as everybody know, where there is associated shock with the pneumonia and tachypnea, PF ratios low, multilobar infiltrates, confusion, uremia, CUB65 score, leukopenia, thrombocytopenia. These are all, like even CAPE-COD, they defined their own the population. Along with this, these are all the symptoms, the signs when they are there. You call it as severe CAP, and especially you resort to go for starting the hydrocortisone. So the recommendations finally are the giving steroids to patients hospitalized with severe bacterial CAP, and as we were discussing about what is severe CAP, and no recommendation those without less with less severe CAP or without severe CAP. So that is how they are helpful. So the dosing regimens, it can be varied, like as we were discussing about the hydrocortisone, which was given in the CAPE-COD study, 200 mg daily. Some people give it as infusion 24 hours. So this is how the role of steroids in CAP can be discussed. So the next, another one or two roles. So the pre-extubation, most of the times we think that the patients who have a difficult intubation and there is expected the trauma was trauma occurred during intubation because of difficult intubation, we expect the patient lands up in airway edema. So these patients, especially the patients who are going to have stridor, high risk reintubation, when the steroid was given 4 hours prior dexamethasone, in these patients, the airway edema and occurred less and tended to have less reintubations across different studies. The corticosteroids, especially in high-risk patients only, are helpful to prevent reintubation in these patients. Routine use is not recommended because most of some centers they follow for all patients who are more than 3-4 days intubation, they tend to give steroid, but that should not be the way that we practice. And much debated, I think, but the practice translation, which the practical translation or practice translation will not happen, because most of the times the patients who present with spinal cord injury, especially the neurologists, tend to give the methylprednisolone high dose. But I think across different studies like NASCIS 1, 2, 3, it was not much shown any benefit giving methylprednisolone high dose in the initial periods of time. They have compared even 3 hours, more than 3 hours, but not much. And most of the spine related, like Canadian spine guidelines and all, they don't recommend giving steroids in patients who had a traumatic spinal cord injury. So come to the summary of recommendations. Other than these, there are, of course, other indications like especially the autoimmune flare. You see SLE flare. You see the patient who presented with DAH, diffuse axonal hemorrhage. And those are other patients also we give, but there it is straightforward. These are the sepsis, ARDS, and CAP, most of the times much debated. As the summaries, the steroids are suggested in septic shock patients, regardless of pressor dose, and should not use high dose and short duration. Rather, a low dose around 200 mg of hydrocortisone, maybe along with fludrocortisone for until the vasopressor dose weaned off. ARDS patient, early is better. So I think ideally it should be less than 7 days. Those patients, I think more phenotypic differentiation. If there is hyperinflammatory, especially those patients respond well. Community acquired pneumonia, of course, the based on CAPE-COD study, probably in or some other studies, probably REMAP-CAP and the patients who have a severe CAP, once we exclude the influenza pneumonia, probably it can be tried. Some of the studies even included influenza pneumonia. They did not show much of outcome difference, but I think influenza should be excluded at this point before we give steroids in all community acquired pneumonia. Thank you. Thank you, sir. Over to you, sir, Venkat, sir. Hello.
Thank you, Kaladhar. 1 second. Thank you for that overview, for giving that extensive overview. Now we have Dr. Jose Chaco, sir. Sir, any crisp comments on this? Then we will take questions and we have some interactions to happen. Over to you, Jose, sir.
Thanks, Dr. Venkat. I hope I am audible.
Yes, sir. Yes, you're audible, sir.
So as Dr. Kaladhar mentioned, there are 3 core areas where we would focus on in today's discussion. First is septic shock. Second is community-acquired pneumonia. And third is acute respiratory distress syndrome. Just to summarize the efficacy or utility of corticosteroids in septic shock, there's a very strong physiological rationale for the use of corticosteroids in septic shock because it inhibits nuclear factor kappa B, and thereby it reduces the generation of the inflammatory cascade, including the interleukins, which are the cornerstone behind the profound vasodilatation and shock that we see among patients with sepsis. So although there was a strong physiological rationale, and studies were done over the last several decades, in fact, many of the initial studies did not show a positive benefit with corticosteroids. There could be 2 reasons. One is to choose the right time to give this corticosteroid. Second is to choose the right dose. And of course, the duration of treatment may also be important. And the first study was the Annane et al. Trial back in 2002, which showed a mortality difference, improved survival with the use of a combination of hydrocortisone and fluorocortisone. Subsequently, the CORTICUS trial could not reproduce the same benefit. Annane was also part of the same investigation team, but they could not regenerate the same results that they found in the initial trial of 2002. Then came the ADRENAL trial, which did not show a difference in mortality, but it showed earlier shock reversal and a marginal reduction in the duration on ventilation. The APROCCHSS trial, Annane et al. Again, who used the same combination of hydrocortisone and fluorocortisone, it showed a mortality benefit as well. So where do we stand today? There is a strong rationale to use corticosteroids in patients with septic shock. As you very rightly mentioned, Dr. Kaladhar, there is no reason to use steroids if there is no shock. It should be confined to patients who are in shock. And also, you need to be very sure about the dose that you're using. High doses, as were used previously in the bygone era, are not recommended at all. What we would commonly use is a dose of 50 milligrams, 6 hourly, or a continuous infusion dose of 200 milligrams per day, as the ADRENAL trial used. A very good reason to use corticosteroids would be that none of the trials have shown a real harmful effect with corticosteroids in septic shock, as in increase in nosocomial infection or even polyneuropathy, myopathy. That's not really been demonstrated in patients with septic shock. So on the balance, there is nothing to lose if you use corticosteroids in septic shock. And almost uniformly across the board, almost all the studies have shown earlier shock reversal. and earlier weaning off of vasopressor support. So today we have strong recommendations from most bodies which support the use of corticosteroids in septic shock. When it comes to community-acquired pneumonia, again,
a few doubts or a few interactions which we want on septic shock, sir.
Yes.
So I think the guidelines been little different from what I think Kaladhar and you opined. Like, it's not just shock, but refractory shock to the vasopressors. That's what they mentioned. How do you take that point? Like, if a patient is maintaining MAP of 70 on a minimal dose or a moderate dose of norepinephrine with 0.1 to 0.2 mics per kg per minute, do you still recommend to use hydrocortisone of 200 milligram? Or is it only when the dual vasopressors in the form of NORAD, vaso, or maybe addition of an adrenaline is required to maintain a MAP and the patient is not able to sustain the MAP? Is that the point? So shock is clear. I think nobody will use hydrocortisone or any form of steroids in a patient without a shock. But in the shock, is it at the beginning or is it at the point where you need a second vasopressor, or at the point where after second vasopressor also you are not able to maintain the MAP?
From from the evidence we have today, in fact, it's very important to look at the original Annane paper and the Corticus trial. The Annane paper actually showed benefit with corticosteroid. In fact, he started corticosteroids within the first 8 hours of shock. That was the inclusion, one of the strong inclusion criteria. While in Corticus, they had a time window of 48 to 72 hours. And the contention at that time as to why Corticus did not show a benefit may have been because they were using it too late. So that's a point that you need to consider. If you are too late, you may not be able to, you may have missed the bus anyway, and it may not really improve matters at all. So earlier may be better, but then how early is an open question. That is a little bit debatable. In my personal opinion, this is a personal opinion, I wouldn't wait till you are on vasopressors and you're on a dose of more than, say, 0.5 micrograms per kilogram per minute of noradrenaline. I would start relatively early, but not really with any dose of noradrenaline. I would wait for a reasonable dose of 0.2 to 0.5 micrograms per kilogram per minute. At that dose level, I would perhaps, it's again my personal opinion, I cannot see any kind of absolute cutoff in terms of available literature in that regard.
Right, sir. There are two other queries and interactions to have, sir. Many of the trials, as you mentioned, couple of them, when they added fludrocortisone as a molecule from the hydrocortisone, we know it has a mineral corticoid activity itself. So we most of the times don't consider as a kind of a logical thinking that it has its own inherent mineralocorticoid activity. But the trials which were done when a mineralocorticoid is added in the form of fludrocortisone in a dose of maybe 0.1 milligram or 100 mics in these patients, they had always been shown to have a mortality benefit in these trials. So any comment on that? Even though hydrocortisone has some mineralocorticoid activity, does this addition in these trials had made any difference?
It is a little bit questionable because both these studies which use fludrocortisone were done by Annane et al. So he's a fan of fludrocortisone.
Okay.
So it's difficult to tell. Other studies have not really used fludrocortisone. Like the ADRENAL trial, which also showed a benefit in terms of shock reversal and reduced time on ventilator, although there was no mortality difference. Even they did not use corticoid specifically. They used hydrocortisone, 200 milligrams per day as a continuous infusion. So it is not really been compared. There's no study that compares hydrocortisone alone versus a combination of hydrocortisone plus fludrocortisone. So we cannot really say that adding fludrocortisone does make a difference.
So the third part of my interaction is there are a lot of metabolic resuscitations were thrown to us from 2019 of the Paul Marik trial, and we now have at least conclusion that high doses of vitamin C as a therapy in the sepsis or a septic shock has no more been valid, with the inclination towards adverse effects more than what we benefit we see.
Yeah.
But again, we are keeping hydrocortisone or a steroid on board. And now the second component of that metabolic resuscitation was thymine. And many of us, whenever we see a patient who has a risk factor for thymine deficiency and has a hyperlactatemia, we tend to use or supplement thymine in an adequate dose. And the next question is the normal dose of ascorbic acid in any form or a use of thymine in any form in your practice believe has any role to play, or in any other form of combinations of any other metabolic resuscitation still has any role to play?
In fact, the Paul Marik trial was just an observational study.
Yes.
And he used this cocktail of vitamin C, thiamine, and hydrocortisone in a series of patients. There was no comparator group. And subsequently, they tested it out in a randomized controlled trial, which did not show any benefit. That's why it came off routine practice. But as you suggested, in patients in whom you suspect a thiamine deficiency, you may or may not be able to prove it. It makes sense to use it. Vitamin C, I'm not so sure because deficiency is extremely uncommon these days. But thiamine, yes, certainly there may be a role in patients in whom you may suspect a deficiency.
There are some audience questions, sir. Is there any difference between outcome related to hydrocortisone continuous infusion versus a bolus? We talk about somewhere between 200 milligrams to 300 milligrams, 50 milligram every 6 hourly bolus versus 200 milligram every in 24 hours infusion.
Yes.
And there were some questions related, do you use 10 milligram per hour for 24 hours that lead to 240 milligrams per day? Or do you really use that 8.3 milligrams per hour to actually reach that 200 milligrams? Anyway.
In fact, the main reason why Venkatesh et al. Used hydrocortisone as an infusion in Australia in their ADRENAL trial was convenience. I know in Australia, they go a lot by convenience and simplifying things. So instead of the nurses having to administer every 6 hourly, there was no physiological rationale behind it. In fact, people also say, rightly so, that given the pharmacokinetics of hydrocortisone, it's better to give it intermittently rather than as a continuous infusion, because particularly when you start, you need a bolus dose to get the levels up. Yes. So it doesn't make any scientific sense to use it as an infusion apart from practical convenience, really. And so most of the studies have used intermittent boluses of 50 milligrams 6 hourly or somewhere around that. So I'm sure the investigators of the ADRENAL trial, including Bala Venkatesh himself, will be the first to admit that there is no special reason as to why you should use an infusion.
Okay. The other questions are related to meningitis. We all understand tubercular meningitis was an indication to actually use more of a dexamethasone from neurophysician's point of view, maybe 8 to 10 milligram per meter square body area. But streptococcal meningitis, streptococcus meningitis has also been. So the questions related to that steroid role in those form of sepsis without shock. When I have a bacterial meningitis and I am suspecting streptococcus role of steroids.
Yeah, in bacterial meningitis, I think there is the classic paper published in the NEJM long time ago, I think more than 2 decades ago, in which they used a combination dexamethasone first and then antibiotics. That's what they recommended to improve the penetration of the antibiotics into the CSF. So that evidence still holds true to use dexamethasone in that setting, as far as I know. And we do use it in practice as well.
Dr. Jose, we have been seeing this discussion about dexamethasone, hydrocortisone in recovery trial. Even dexamethasone was the steroid form which was initially tried. And then some of us used methylprednisolone and dexamethasone alternatively. And now we are talking about dexamethasone in the CNS because of maybe blood-brain barrier or anti-inflammatory role. And we are talking about hydrocortisone as an acute, short-acting, immediate-acting steroids here. So is it based on different indication or trials done with that particular steroid? What was your take on that?
It is mostly got to do with the evidence in clinical trials with the use of a specific agent. Like the recovery trial, they used dexamethasone. They used it mainly because it was commonly available, freely available in the UK and the countries that participated in the trial at that time. And subsequently, most of the studies have used it mainly out of convenience rather than any strong physiological reason for choosing a particular steroid over the other. To my knowledge, at least, I can't see much of a difference, say, if you're using hydrocortisone or methylpred or dexamethasone in equivalent doses. What is your opinion now?
So most of us in septic shock, yes, as you rightly pointed out, we have been debating the roles of different form of steroids. We know they are interchangeably can adjust it to the dose. 1 milligram of probably dexamethasone equal to 5 milligrams of maybe prednisolone equal to 6 milligrams of methylprednisolone equal to 25 milligram of hydrocortisone. This is the dose which we talk about the interchangeably. But most of us in sepsis, septic shock have been sticking to hydrocortisone, maybe because of its the availability of an immediate action or a shorter half-life and all that. And the use of dexamethasone in those conditions like meninges and all, maybe I don't know whether more of an anti-inflammatory phenomenon, edema, or the anti-edematic measures. But yes, the question still remains with us. Do we can exchange with each other? So we stick to dexamethasone in meningitis. We stick to hydrocortisone in cases of more of sepsis and septic shock.
Yes, yeah, I would go by that. Yes.
So, sir, we will go to the CAP steroids. Then we'll take some questions on the bank, sir.
Okay. So community-acquired pneumonia, again, there is a long history. The first smallish randomized controlled trial was published sometime in the early 2000s, roughly 20 years ago, in fact, Controversies et al., in which it was the first study, just 45 patients or so, in which they showed improved survival with the use of corticosteroids. And subsequently, there have been several studies which over the years have established the efficacy of hydrocortisone in severe community-acquired pneumonia by definition. Not in all pneumonias, of course, only in severe community-acquired pneumonia. And the most recent study was the CAPE-COD trial, DQN et al., which almost cemented the importance of using hydrocortisone in terms of improving outcomes. So as the evidence stands today, we certainly have a very strong evidence base for the use of steroids in community-acquired pneumonia. So apart from the most of the patients who really require ICU admission, oxygen support or ventilator support, it might be a good idea to commence them on steroids early enough. That's what the evidence suggests for now.
Sir,
Yeah. So there are some discussions related to influenza pneumonia. When the clinical trials were done on influenza, we have seen the adverse effects or the benefits were not many, but it was more inclined towards increasing in mortality. So any specific reason you think influenza patients, many trials, not one, could actually see the adverse effects or the outcomes, the mortality was more with those patients who received a steroid dosing compared to the other with COVID, and now we are talking about bacterial pneumonias and all.
It's a little difficult to explain as to why it may not be effective or harmful in influenza pneumonia and beneficial in conditions like COVID-related ARDS. In fact, if you look at the studies, most of the studies with influenza pneumonia were very small studies or observational studies, unlike the recovery trial, which was a very large trial, multi-platform adaptive randomization, which conclusively showed the benefit of dexamethasone in COVID-related infection. So, and of course, the CAPE-COD trial, they specifically excluded influenza pneumonia. So given the current state of evidence that we have, we don't have any evidence to support its use in influenza pneumonia, of course. But certainly in severe bacterial pneumonia, COVID pneumonia, there is a strong rationale for its use.
The second questions in the chat box are duration and doses. It remains the same, or?
The duration has been variable depending on the studies that you look at. In fact, in the Villar et al. Study, they used dexamethasone for 10 days, initially at a dose of 20 milligrams per day for 5 days, and then 10 milligrams per day. So there is no clear-cut evidence as to exactly how long would you use these steroids? Would you need to taper it over a period of time? All these are really unanswered questions, and you cannot really make any kind of strong recommendation.
What is your clinical practice, sir? How many do?
What we normally would do is we would give it for, say, 5 to 7 days time, and by that time you see some improvement, you would either wean off the dose slowly, or maybe even stop it without tapering. That depends on the clinical situation and your clinical judgment.
True. I think we all of us do the same thing, 3 to 5 days as the patient improves on vent, comes out of the maybe severe pneumonia from PF ratios improving, patient getting weaned out of the ventilation. That's the time where we start actually dropping. So regarding the last component in this, the weaning and tapering, is it required, or we just discontinue for this 5 to 7 days?
In septic shock, actually, if you attain shock reversal early within the first 3 to 4 days, at least from the first Annane trial of 2002, long time ago, which actually showed benefit, the first study to show benefit in a randomized control trial, they did not taper down and stop it, they just abruptly stopped it. So I suppose it depends on the duration for which you use it. If you use it only for a short period of time, say less than 5 days or less than a week, you may not require to wean down gradually. It may be safe enough to stop it abruptly. But that again depends on the clinical circumstances, the condition of your patient, and your overall clinical judgment. You need to individualize care. But there is no hard and fast rule that you should absolutely taper off and not abruptly stop it. Of course, the longer you use it, the more likely that you would need to taper it down slowly over time.
Okay, so we'll go to the last component of ARDS.
Yes, and ARDS as well. Ever since Ashpaw and Petty described it way back in 1967, there has been a high level of interest with the use of corticosteroids. And in fact, one of the early studies was the Medjuri et al. Paper, which they published in 1999, just 24 patients in which he did a crossover trial, methylpred versus placebo. And that actually, in this very small trial, it showed benefit. Subsequent to that, we had the ARDS-NET trial, which used methylpred in a proper randomized controlled trial, which was sampled for enough power. But in this particular trial, they could not show any mortality benefit. Not only did they not show benefit, there was also evidence of possible harm with a higher incidence of critical illness polyneuropathy among steroid-treated patients. Then subsequently, there were many studies with conflicting results until with COVID, of course, COVID-related ARDS or CARDS, in which many studies, starting with the recovery trial, showed mortality benefit. The more severe the illness, the higher the level of benefit. That's what the recovery trial showed. And many trials were done with steroids in that era. The CAPE-COVID trial, the REMAP-CAP trial, they all showed a trend to benefit, and they stopped in between because by the time the recovery trial results were out, and it was considered unethical to continue.
Without
Yes. So those were the trials with COVID-related ARDS. And as I mentioned earlier, the Villa trial of 2020, non-COVID patients, here again, they showed benefit with the use of corticosteroid. So the current level of evidence is to support the use of corticosteroids in severe ARDS. But I think one must also consider the fact that ARDS is not a disease in itself. It is just a manifestation of an underlying disease process, which may be highly variable from one end of the spectrum to the other. Like it could be from trauma, or it could be from severe sepsis, and lots of other conditions in between. So you need to use your clinical judgment as well. You wouldn't particularly use trauma-related steroids in trauma-related ARDS to begin with in most patients. So that's where you need to fine-tune your clinical judgment based on the situation, and probably not jump into the use of corticosteroids in any type of ARDS, given that it is not a disease process itself. It is just a manifestation of a disease process.
So you mean to say, sir, pulmonary, extrapulmonary, is that a classification which we can consider pulmonary, severe ARDS, non-influenza induced, consider steroids, and again the drug and dose and duration, all that?
Yes, severe ARDS certainly, but between pulmonary and extrapulmonary, if it's pneumonia related, there is a strong rationale because it does help in pneumonia. So pneumonia related ARDS, you would certainly probably use it anyway. And so it depends mainly on the underlying pathophysiology that resulted in the ARDS to begin with. And in this context, it's also important to consider ARDS mimics, as they are called, like eosinophilic pneumonia, allergic alveolitis, connective tissue disorders, BOOPs, all these conditions. Steroid is positively indicated.
Yes.
And you may not be able to distinguish very well whether it is ARDS or one of these conditions, be one of the mimics. So if there is, if you're in doubt that it could be one of the mimics which are steroid responsive, you would err on the side of giving steroid, considering the overall benefit, I would think. I'm keen to know what others feel.
So there are questions related to autoimmune encephalitis. I think if we have a suspicion of autoimmune encephalitis, either seropositive or seronegative, the doses of steroids are not the lower dose. We are talking about pulsing them, and we will be giving a gram of steroids, maybe up to 3 days of pulsing, and those are all different category. And as Sir mentioned about when we land up in an ARDS or a acute respiratory failure, we have a diverse conditions which causes ARDS, and some of them can be vasculitis, some of them can be organizing pneumonia, some of them can be chemical pneumonitis, some of them can be a lupus-induced the autoimmune condition. So many of them may need steroids, and once proven, the steroid doses has been probably as high as a gram of steroids in many of them when we actually pulse them. So they are all conditions which are probably condition related. These patients need to be individualized to their underlying medical condition for which the lung got involved. But as such, when we are talking about probably ARDS related to the pulmonary causes and pneumonia, other than influenza at this point of time acquired by some bacterial or other viral pneumonias, we use steroids. And sir, there were questions related to hydrocort versus methylprednisolone in severe community-acquired pneumonia?
Most of the studies have been conducted with hydrocortisone. So
Yeah,
personally, I would
stick to.
prefer hydrocortisone because that's what we have evidence for. Does not mean that other types of steroid are not as effective. It could well be as effective. But then in this time and age of evidence-based medicine, it's best to stick to the evidence we have, I feel.
So I think we had a very interesting and fruitful, wise discussion from Dr. Jose. I carry three important messages for this discussion. The first, in all form of septic shock, when your vasopressor doses are in upscaled manner, considering a steroid supplementation early, not too late, has been shown to be beneficial without any much adverse effects, including increase in infection rates, increasing in GI bleeds or any. So in those situations, you are not doing any harm. So your mortality benefits may not be shown in many trials, but I think we all consider the hydrocortisone either in the form of infusion or in the form of intermediate boluses. Probably we have more scientific logical rationale to use 50 milligrams every 6th hourly over an infusion as far as the pharmacokinetics and dynamics of hydrocortisone is concerned, and also the initial dose where you need the role of the steroid to act on and help your vasopressus dose to come, because infusion of a 8 milligram per hour or 10 milligram per hour may take a longer time for your blood levels of those steroids to achieve. So that's a take-home point. Number two, in all form of severe community-acquired pneumonia, needing any invasive mechanical ventilation or any form of intensive care admission with a severe form of pneumonia, other than influenza at this point of time, will receive a steroid dose. The duration remain to be on practically at this point of time 3 to 5 days. We don't have a standard cut-off guidelines at this point of time, and all the trials have not shown to increase any critical illness polyneuromyopathy or any adverse outcome in all of them. So probably in a severe community-acquired pneumonia, we are using steroids. Choice of steroids, yes, there has been debate of many, but Dr. Jose has concluded that the trials at this point of time are done on hydrocortisone, so we are still sticking to hydrocortisone as a steroid choice in them. The last component is ARDS. ARDS is a heterogeneous syndrome rather than a particular disease. So pulmonary, extrapulmonary underlying causes may have a role to play. We have not had enough of literature evidence suggesting a role of steroids in all the spectrum. Probably a pulmonary origin with a pneumonia being the source, as we already know, severe community-acquired pneumonias has shown to be beneficial. In those scenarios, maybe steroids has a role to play. And many of the trials were done with methylprednisolone, if I'm not wrong, sir, in all those ARDS patients, varying between a milligram to couple of milligrams per kg body weight, varying between weeks to maybe 2 weeks or more. The duration has been much higher in many of these ARDS patients. Maybe that is one reason, sir, why we have seen in arsenate trial the increase in critical illness polyneuromyopathy, whether the same thing has not been seen in community-acquired pneumonia and septic shock patient. Is that been a possibility, sir?
That is quite possible because they used it for, I think, something like 21 days and then weaned
Yes.
down over the next week. So that was a pretty long duration of treatment. And of course, the longer you use it, the more likely you are going to get neuropathy, particularly if you combine it with muscle relaxants. That's also another thing to consider.
And which commonly happens during most of these.
Yes, you do use muscle relaxants very commonly.
Kaladhar, any points to conclude or any questions to sir?
Right, sir. Yeah, much of the points were discussed, sir. I think the steroids are double-edged, as we think, especially as we were discussing in ARDS, much prolonged periods, and should be used early. Most of the studies, like those who use delayed after much of the course of the disease happened, and then use, there is no point in much of effects happening from that. So probably early and not very prolonged duration. That is the clinical point I can say. Other than that, yeah, they are double-edged. We have to be watchful of any secondary infections developing where the dose has to be, or otherwise we have to stop the steroid at that point. Because these patients who are on ventilator quite a time go on to develop a secondary infection, something like ventilator-associated pneumonia and all. So that is also we should be watchful, sir. Yeah.
But
Other
Kalada,
than that,
point to make, I think this has not been uncommon to me. Many of our clinicians do ask, the patient may catch a secondary infection, or there are also discussions to me that the patient had some infection, so why do we use steroids in them? So we are talking about sepsis, bacteremia, shock. And we are talking about these stress dose steroids, which we are talking about around 50 milligrams to 200 milligrams. So we are not worried that this 50 milligrams every 6th hourly of a 200 milligrams of hydrocortisone will increase the risk of infections. I think no trial at this point of time has enough of that evidence that this increases infection. So many of the times when I discuss with my clinician in this debate, so I say probably this dose, we don't carry a risk of increasing the chances of any infections. What do you say, Joseph, sir? Is that take?
Yeah, I strongly agree with that, particularly in septic shock. If you're giving adequate wide spectrum antibiotics, you're covering infections anyway. And as you rightly pointed out, one of the hallmarks of all the randomized controlled trials in septic shock has been there has been no increase in the incidence of nosocomial infections compared to the placebo group, as was feared. Now that has shown to be not really true. And in fact, the other adverse effects as well, like neuromyopathy and GI bleed, they've also been not shown to be higher, specifically in
hypertension.
septic shock patients. So on the whole, at least in septic shock, you could say there is nothing to lose really by even erring on the side of giving steroids too early. May not be able to say as much for, say, pneumonia or ARDS, but certainly in septic shock, even if you are on the side of giving it a little too early, that's my personal opinion. It should be all right.
I think the
Yeah, do you think ARDS is different from septic shock, sir? Yeah, as septic shock is more of a dysregulated host immune response. That's what we generally target by giving steroids.
Yeah.
ARDS patients is also like most of the times hyperinflammatory phenotype is the one which we generally target. Do you think as compared to septic shock patient, ARDS patient, because their lung is already compromised, so after maybe 3 to 5 days of steroid, do you think that they don't land up in secondary infections as compared to septic shock and all? I think not much trials have evaluated that. There is increased risk of infections, but it did not attain the statistical significance. That's what I could read in especially ARDS patients.
Yeah, probably true.
Maybe what we have seen during COVID, the erratic use of higher doses of steroids, grams of methylprednisolone, 500 milligrams of methylprednisolone, indefinite period, over enthusiastic higher doses. These are the reasons, not just a bacterial infection. We have seen mucor coming in, infections coming in, many more. So we are not talking about those doses, and maybe coming to the ARDS, if you are using prednisolone or methylprednisolone 1 to 2 milligrams per kilogram over maybe 2 weeks or more, maybe you carry a risk of increasing infections in them. And Joseph sir made a very interesting point in ARDS. ARDS being such an heterogeneous situation, you have to take case to case basis. Not all ARDS patient you blankly will be initiating steroids, but many of the times you may have an indication and underlying condition. As we know,
Do you think any inflammatory markers have to be like CRP?
So that is again a very interesting point, that
interleukin
you
6.
don't phenotype your ARDS now. You don't have a way to phenotype whether it is in hyperinflammatory or hypoinflammatory based on your all markers. Then the second question comes: steroid responsive, steroid unresponsive. So that will be a million-dollar question in the future to answer. Which case of my ARDS will respond to steroid and get benefit, and which phenotype of my ARDS will have adverse effect or harmful effect. Will that be an area of maybe future, sir, Jose sir?
It is, should be something to look at in the future. In fact, there have been some studies which have used CRP levels to determine whether it's pro-inflammatory or not. Similar to that, maybe if you can measure interleukins or any other mediators and go by that, maybe that's one of the considerations for the future, definitely.
I have seen some studies where they use ferritin, interleukins, CRPs, and the markers, and then they said, okay, somebody who has all of this being going high and high. So I'm not sure, but these are all different ways of actually identifying or trying. Even in sepsis, they are saying ferritin been used. If not a full-blown HLH category or HLH score is high, but your ferritin is on a rise, then you consider there is ongoing some amount of hyperinflammatory phenomenon from you.
Yeah, they are unexplored territory. You need to further delve deeper into those areas.
Thank you, sir. Thank you very much, Kaladhar, for
Thank you.
this presentation in that short period. And Dr. Jose Chacko, sir, you have been phenomenal in these all controversial zones, very calm and quiet. You have answered all those questions in such a way that the take-home message has been clear, and without going into any unwanted complexities and controversies, you put those other areas which are under probably a futuristic trial. So thank you very much for bringing those interesting voice.
Thank you, sir.
Pleasure to be here. Thank you.
Thank you all the audience and participants for being with us and asking and interacting so many questions. Thank you for being with us. I conclude the session. Thank you.
Thank you, sir.
Bye.